Today we will discuss 10 antimicrobial diagnostic traps that we commonly miss. There are situations where antibiotics are started reflexively, but the real diagnosis is something else. A frequent bedside mistake made in the wards and more so in the ICUs. Fever in the first 48 hours after surgery, you reflexively start a broad spectrum antibiotics. Reality, most early postoperative fever is inflammatory and not infectious. The common causes is tissue injury, atelectasis, cytokine release, and blood transfer reactions. The surgical site infection usually appear from the 3rd to 5th day. Persistent fever despite broad spectrum antibiotics, you try to escalate to higher antibiotics. In reality, often source control failure is the cause. Example, abscesses, emphysema, infected catheters, or obstructed biliary system. No antibiotic can ever sterilize an undrained abscess. Pyuria does not always mean UTI. This is the third trap. Treat pyuria with antibiotics. In reality, pyuria occurs in catheterized patients, interstitial nephritis, renal stones, tuberculosis, and asymptomatic bacteriuria. Treat UTI only when symptoms are present. Positive blood culture does not always mean infections. The trap is to treat every positive culture aggressively, but in reality, many may be contaminants. The common contaminants pattern can be identified. The cons, coagulase negative staphylococci, Corynebacterium, Bacillus species, and Propionibacterium. Single blood positivity should raise some suspicion of contamination. The fifth trap is diarrhea for antibiotics. After antibiotics, there are not always infections, and starting metronidazole reflexively. Most antibiotic-associated diarrhea are not due to Clostridium difficile. Clues suggesting difficile is recent antibiotic use, leukocytosis, severe abdominal pain, and positive toxin test. Fever in the ICU automatically called as sepsis usually, and this makes us to escalate antibiotics. In reality, ICU fever may be due to drug fever, thromboembolism, pancreatitis, adrenal insufficiency, or even transfusion reaction, which patients often get. And many of the fevers in the ICU are non-infectious. Next trap is elevated procalcitonin, always mean bacterial infection, and starting antibiotics wholly based on this. Procalcitonin can increase in major surgery, trauma, burns, cardiogenic shock, and severe malaria. So procalcitonin should support clinical judgment, not replace it. Next, seeing chest X-ray infiltrates and thinking it as pneumonia. Treat every infiltrate with antibiotics. Radiological infiltrates may present in pulmonary edema, embolism, ARDS, cellular hemorrhage, and atelectasis. Always correlate with clinical symptoms and inflammatory markers, and then go ahead prescribing antibiotics. Fever with leukocytosis automatically means infection is the next trap, and antibiotics are started. In reality, leukocytosis can occur with steroid use, stress response, in hemorrhages, in myocardial infarction, and in diabetic ketoacidosis. So leukocytosis alone is not evidence of infection. And the last and the biggest trap is to treating reports instead of patients. Antibiotics are started for mild cultures, colonizers, and lab abnormalities. Colonization is not equivalent to infection. For example, Candida in urine, bacteria in the tracheal aspirate, positive wound swab without clinical infection. These are not to be treated. So before prescribing a new antibiotic or changing an antibiotic, ask, is there clinical evidence of infection? Do I know the likely source? Is antibiotic therapy truly needed? If the answer is clear, pause and reassess.